So as Joe said, provost is code for second in command at the university. I'm a professor of physics, which is code for about 200th in command at the university. But I'm happy to be here to introduce our speaker, Brigitte. So I'll give you a little bio, and then we'll just let Dr. Cypress speak. Our speaker this evening, Dr. Brigitte Cypress, was born in the Philippines and has lived here in the United States for the past 26 years. She is a graduate of Teachers College Columbia University with a doctorate in nursing education and has been a practicing CCRN and RN in New York City for the past 17 years. And we've been fortunate enough here on the campus to have had her as an associate professor since August of this past year. So she's one of our newer arrivals, and we're very happy that she's here. Dr. Cypress is a qualitative researcher and phenomenologist, and she will be sharing with us this evening results from some of the research that she has carried out focusing on the intersection between patient, family, and care provider roles in critical care settings. So please join me in welcoming Dr. Cypress.
Pardon me, I don't have a clicker, so I'll be back and forth. I'm so happy to be in front of you today. Thank you so much for coming. My dean is here, so I'm speaking from College of Health Sciences, and I've been to every single one, and I'm coming entirely different from those that were before me. I'm coming directly from practice, from nursing practice, so I'll be talking about patient and family care. So I'm so happy to see my students here today, and thank you, Dr. Bruno, for giving me this opportunity to talk. I actually have a little guilt because most of the time I speak outside the country, so to speak in front of you, and this is my job where I work, I am so honored, so thank you so much. So what I'm gonna do first is I'm gonna give you some background of why qualitative research, and my area, by the way, is critical care, which I've worked for a total of 18 years, 17 and a half, actually total 20, 17 and a half were in New York. So the context of where I did the study, and then the population, and the type of study was within the context of New York City. Okay. Actually speaking is what I love to do, presenting my findings, and I'm very honored, I said, to be here, especially that this is my area of work. Okay, so this will be the topics for my presentation. It will not make sense right away at the beginning, but as we go on, you will know what I mean when I say research, qualitative nursing research as basis of empirical knowing, and I put a question mark because some might debate me on that. Praxis and theory, what I do and how it relates to theory, development of nursing knowledge, and policy as an outcome of my studies, and also some contributions to evidence-based practice and policy. Okay, so just a little background. As I said, I'm a critical care nurse, and I've been doing it for 18 years. Just some background about this. Between 2002 and 2005, critical care medicine, this is the cost, from 56.6 to 81.7 billion. ICUs consume 13.4% of the total inpatient expenditures and 4.1% of the national health expenditures, which equals to almost 1% of the GDP. That's in the US, and this is the current, these are the current numbers. So more than 5.7 million patients are admitted annually to intensive care units in the US for intensive or invasive monitoring, support of airway, breathing or circulation, stabilization of acute or life-threatening medical problems, comprehensive management of injury and or illness, and restoration of stable health status or comfort while dying within an interdisciplinary and collaborative environment. So about 20% of acute care admissions are to an ICU. Up to more than half of emergency department admissions result in an ICU admission, and ICU patients are like a mix of patients, but all share the need for frequent assessment and greater need for technological support compared to patients admitted to non-ICU beds. So the most common technological support is mechanical ventilation. So that means that those patients need life support, as what we say in common language, and with 20 to 30% of ICU admissions requiring this type of intervention. So I'm gonna put it or relate it to money. So for those who require mechanical ventilation, believe it or not, it's not so cheap. So it's cost a lot for the expenditures that they have in inpatient. So for length of stay for about 2 weeks to 15 days, it would cost about $32,000 to $43,000. But for those requiring not requiring mechanical ventilation, between $13,000 to $20,000, and that's for like 8.5 to 10 days of stay. So the daily costs are greatest actually on day 1 of ICU stay. So about $11,000 for the first day when they're on life support, and if they're not on life support, about $7,000. So in my ICU where I used to work, I know it's $5,000 a day. So cost is decreased on day 2, about $5,000, and for those who are not mechanically ventilated, about $3,500. So stable patients, for example, on day 3, about $4,000, and no mechanical ventilation, $3,200. So as they go along, when they're stable, minimum ICU stay is about $1,500. So that's really a whole lot of money. So who is affected with critical illness? About 80% of all Americans have been affected by critical illness. So nearly 80% of Americans will experience a critical illness or injury, either as a patient or a family member or patient's friend. So 1/3 to 1/2 of Americans spend time in ICU during their final year of life, and 1/5 die in there. There are only 3 outcomes for ICU patients. It's either they get better and get transferred to the floor, or they die, which is very common, or if they get discharged, they are transferred to like a rehab facility. So, but unfortunately, a lot of the outcomes that I see, a lot of them die in ICU. So that's just giving you the numbers. So in 2001, the Institute of Medicine identified involvement of family and friends as one of the dimensions of patient-centered care. And the reason I'm showing this, because my work it always includes the family, not only the patient, and including the nurses. So actually, this dimension of patient-centered care focused on accommodating family and friends on whom patients may rely. So I will focus on the first study, which was, I had the first study in ICU, the second in the ED, and the third one, combination of both. So I am a qualitative researcher, but doesn't mean that I haven't conducted a quantitative study. Actually, my master's thesis was a quantitative study. But I am very much, passionate about knowing the meaning of illness, especially critical illness, to patients and family, and also the caregivers, which are the nurses. So you can do any measurement that you want with quantitative studies, but I want to go more than that. I love talking to my patients and family members, and that's why my study is mostly on that. So as this is a qualitative study, specifically a phenomenological study, the phenomenon of interest was this: the lived experiences of patients, their family members, and their nurses during critical illness in the ICU. So the purpose, as again, this is a phenomenological study, first I have to know, is there anything done about the topic out there in the literature? There are actually studies, but mostly the studies are done, it's either patient and nurse, family and nurses, but nothing that includes the 3 of them. So it may look like a triad, patients, family, and nurses, but the way I looked at it was I asked patient and families their perception of the nurse as the caregiver, and I asked the nurse what is their perception of patients and family of critical illness in the ICU. Okay. So the purpose, of course, as it's a qualitative phenomenological study, was to explore, illuminate, describe, and understand the meaning of ICU experiences of the patients, their family members, and nurses during critical illness in the ICU. So look, checking the literature, there is nothing, a study like that includes the 3. Okay, and also people might ask me, how did you think of the study? As everyone knows, I'm sure my mentors here, who's been here before me, the hardest part of a research is to think of what to study. So it took me 18 months to think of this study. What happened was my mentor was in the ICU one time, and we were thinking of what I will study. And then she said, "Oh, Brigitte, why don't you do this? I'm sitting here in the ICU with my brother as a patient, and I'm seeing the nurse back and forth. And I'm thinking, I wonder what she thinks of me as the family and my brother as the patient. and also how we perceive the nurse. So, and then I said, yeah, that would be good. Let me check the literature. And then I found out that there's none. Okay, so these are the research questions. Pretty simple. What are the patients and their families' experiences of the nurse in an ICU unit environment? And what are the nurses' experiences of the patients and families in an ICU environment? By the way, also about thinking of a research question. I did first go around my colleagues, whom I've been working with for 18 years, and I asked, what do you think would be a nice topic to study, like for research? But I know I'm the only one in school, and they said to me, Brigitte, we're not in school, so don't ask us. Like, we have no idea, which is actually true. If they're not in school, they're not really interested. Then I asked again, another one, and I said, what do you think would be an interesting topic to work on? And she said, I don't really care, I'm retiring, so I don't know about your question because I'm not in school. So I said, okay. But the other person I asked was my best friend. She said, I did master's with you, I don't want to go further, so I don't know the answer to the question. So it was tough, but after 18 months, I got it. So as in any phenomenological study, you actually have your approach, whose approach for phenomenology, phenomenological method. There's a philosophical perspective, and there's the conceptual, which I used Roy. And this is not actually so easy to do, but it took after 18 months, and the data analysis was long. So I don't have the methods here in detail. I planned for 30 participants. So I planned for actually 10 nurses, 10 patients, and 10 family members. Of course, there's a criteria. The question that I always get is, how did you interview the patients if they were critically ill in the ICU? So I didn't look at any diagnosis specifically, but any diagnosis as long as they're critically ill. After they get transferred to the floor after 4 days, I do the cognitive test. There's a scoring, and there's a certain number. If I can say that they're awake, alert, to name person, place, and time, and they're able to answer talk to me in an interview, then they are a candidate. If they don't pass that cognitive test, then they cannot be, because I have to talk to them and interview them 2 times. So that's why, but after I did 15 of them, actually I got enough data. I had data saturation, and of course you ask experts, what is it that I'm experiencing, I'm asking? How come I get the same answer from within this category of patients, nurses, and family members? And then I see the same commonalities across. And then the expert said to me, oh, that's triangulation of data, so you're good. And then, okay, that was really a good feeling. So that's why it's hard, because I have to use these 3 approaches. So triangulation of data, actually, I said thank you before to Dr. Fawcett, who helped me, coined the word. Okay, so what I found from the study. So basically, this is like a summary of it. From the patients, there's a patient-specific theme, there's a nurse-specific theme, and there's a family member-specific theme. But the common integrating themes are this in the middle. So family as a unit, I asked an expert how to term that. So just that I'm comfortable that is correct. Physical care and comfort, physiological care, psychosocial support, with communication as the precursor for psychosocial support and transformation. There's descriptors for each one of them. Okay, so I just want to let you know that this is qualitative, so I'm going to read some actual narratives from the participants. So there are some of it for each one. So the common themes, family as a unit. Okay, I already know from the literature that as an ICU nurse, when I admit a patient who's critically ill, I don't only deal or do interventions with the patients, I actually include the family. So if I ask the audience, if your family member is sick, especially critical care, ICU, are you affected or you're not affected at all? It's always, there's actually, the family is always affected. Maybe it be role or a lot of things. It's not only the patient that's affected. But there is nothing in the literature that says, because one of my findings, family as a unit, is I look at them as a unit. But I did not know that the patients and family members include the nurse as part of the family. It took me long how to put the term family as a unit, I had to ask 2 experts about that, me and my mentor. So that's a new finding. I did not know that, not in the literature, that the patient and family members look at the nurse as part of the family. Again, the context is critical care, so it might be a little different with medical surgical when a nurse has 10 patients compared to 2 patients in the ICU. Physical care and comfort, some of them, actually, the descriptors are familiar: physiological care, psychosocial support. Transformation is one significant finding, and I'll tell you about that. And this, So, family as a unit. The family, actually, all of them said to involve the family in the plan of care or be an active participant. Allow family to bring pictures of the patient and empathize with the family. So I'll give you some examples of what they said. One nurse said, family member, with the nurses, it was like becoming a family. Every time we go to ICU, I wouldn't look at them as nurses. They were all like part of our family because they were so caring and making sure that we as the family, we knew that what was going on and that things were going to be all right. It became like you know them and they were like part of you every day. By the way, in qualitative study, I have pages and pages of transcripts, which is transcribed by a professional transcriptionist. Not so easy because it takes months and months and months. And if you're a qualitative researcher, they say, bring your wine to the beach and do your data analysis. That's what I did, but no wine. Okay, allow family to bring pictures of the patient. If you have seen a critically ill patient, they don't like the same person, they don't look like the same person as they were before. Especially if they're all swollen and you cannot recognize the face, you would never recognize the face. So this nurse said, sometimes patients are unrecognizable because of their critical care condition. They really look bad and messy. I remember the family member put a picture in the patient's room. By all means, allow the family to put a picture of the patient in the room. This way, you picture the patient as a person that you're taking care of and not just a sick patient connected to all these machines. You are taking care of this different looking person rather than a sick guy whom you cannot recognize with no face. Putting the picture helped me think of the patient like a regular person. So, if you look at the patient in the bed and you look at the picture on the wall from the family, it's really, really different. So, they feel good. The family said that we feel good to think that, yes, this is him. He's just sick right now. So it's not a good, and I don't think it's anything bad if we allow the pictures in the bedside. So physical care, nothing. It's bathing the patient, rendering oral care, encouraging touch, treating the pain, and ensuring that the room is clean. One big significant thing here is encouraging touch. I encourage family members to hold the hand of the patient and continuously talk to the patient even though they're on life support. Even though they are on induced coma and they're on sedation, but they can hear you. So I always tell the family members, continue holding the patient's hand and talking to them. But one significant thing that I found in this study are the nurses are doing the same. Like for this nurse. It's important in critical care that you encourage family members to hold the hand of the patient, especially when they are talking to them. Even when they're on life support, I would say, John, I am here, I'm Brigitte, I'm your nurse, it's 7 o'clock, I'll be here up to 12, whatever time, and I will be back and forth, I will always let you know what I do, because they can hear. Believe it or not, I have many patients who came out from coma, if it's chemically induced coma, and they ask the question. One funny thing was we don't have the Pyxis before, so we use narcotic keys to open the narcotics. When the patient was extubated and awake, the first thing he asked, what is this narcotic keys that you guys are looking for? I hear it all the time. So that's why I tell my students, do not gossip, do not talk about anything in the bedside because they can hear, even though they're comatose. So the nurse said, I usually hold the hand of my patient. When I was a medical surgical nurse, I had a demented and confused patient who said to me, just hold my hand and I'm going to be all right. That's something that I will always remember, and I believe that touching them and trying to let them feel that there is another person with them is good, so that they don't feel alone and somebody is trying to help them. It's like an assurance that somebody will help them and everything will be all right. Okay, treating the pain. Do you know that if they're on life support, they still feel pain? As a critical care nurse, I know exactly when they're in pain. Of course, they're not able to talk because they're on life support. They're tachycardic, meaning very fast heart rate, very fast breathing, even though they're on life support. And they're sweating, and they're restless, and they're trying to bite the tube and trying to yank it out. That means that they're in pain. You will know this as you go along with your experience. So treating the pain. In ICU, we get all kinds of patients, all kinds of diagnoses, may it be trauma, post-op, or acutely critically ill patients. Pain is pretty much a very common problem. Even an intubated patient can be in pain, exactly what I'm saying. Nurses should be able to assess them well, for they are unable to verbalize. Believe it or not, once you give the pain medicine, they come down. All the vital signs become normal, and they go to sleep, and they feel okay. So doesn't mean that because they're not able to verbalize, you do not address the pain. Pain is the 5th vital sign. So actually, if you're going to an alert patient after you take your vital signs, the question that you ask next is, are you in pain? So even with these critical ill patients. Ensuring that the room is clean. If you can imagine in your head right now, when we have a code in the room, there's like 2 teams, like 10 people, and then there's a lot of machines. And believe it or not, patient and family said the ICU is the place where there are lots of these machines and equipments. A lot of procedures being done and other things going on most of the time. There are also a lot of personnel who checks on you all the time. It could be chaos, and when all of them are out of the room, I want to have my room clean and in order. But in spite of all that, the nurse and housekeeping made sure that the room is clean. Sometimes there's a lot of blood. There are sharps in the room. There are machines. And can you imagine a patient is aware of this and saying that I want my room to be clean, same as the family. Okay. Physiological care. This is when you take your vital signs, you give medications, and feed the patient. I don't have narratives for that. I'm sure it's self-explanatory. Psychosocial support. This picture is, I'm just giving homage to my mentor. That's her cat. She died already. Emotional support could be in different forms and encouragement. Spiritual support, sensitivity to patients and family members' needs, and respect. I'm so glad I have my students here, and I go with you to clinicals, but guess what? They said, when you come in the morning, that's not according to me, okay? For all my participants, you have to introduce yourself. First of all, you have to show your ID. They actually told me, Brigitte, why is it that I don't see the ID? It's flipped. Are they scared that I'm going to report if I have some complaints? So introduce yourself. Your ID should be there. You should be open to questions, that if they have questions that you try to answer, but only up to whatever you could answer. If you could not answer because it's not within your role, then you can refer to the doctor. They also said, reflect on your conversations with them. Let's say a patient and family said, can we please speak to the social worker because we have something. Sometimes they said that the nurses forget and they remember that. Then they would say, what happened? Why she didn't relay the message? And I always say to my students in clinicals, say goodbye after the shift. They actually look for you and say, where's my student nurse or where's my nurse? She didn't say goodbye, so they want that. Simple as that. Sensitivity. Just again, the context of this study is in the Bronx in New York. So we have our patients, a lot of them are low socioeconomic status, and a lot of them are, we say, on welfare, okay? So they said, one of the nurses gave the telephone number at the desk to call her when I get home or anytime. She was so nice to give it without me asking. I did not think of it then. Then she asked me, do you want the telephone number? And I answered yes. I was happy that she offered it. The nurses were very good with the family members. They were always there. When you ask for anything, they bring it. They always answer the questions, and when you ask, and they know. They dealt with me good. Some of my patients said, I hope that the care that we get is the same as those with insurance, for example. I'll give you an example. For our ER every night, there's like 300 patients. Half of them, or almost half sometimes, actually that's our charity with no insurance or something. So they feel like, they hope that the care would be the same as those with insurance. Okay, treat the patient with and family with respect. The nurse was nice in the way she treated people, the way she talked. We needed to talk so I could know about you and you could know about me, meaning I'm your nurse today. Just at least to introduce. They were good. I got along with them well. The nurse took care of me. Good, for she treated me with respect, and she also treated her with respect. I treat people the same as I want to be treated. Okay, transformation is one of my big findings, and I got this from Callista Roy, a nurse theorist. The finding about transformational is consistent with the highest goal of adaptation. So the nurses who's been there for so long, taking care of critically ill, they said actually that the experience made me grow as a person. The experience makes me more enthusiastic for learning, and realization that good care equals family satisfaction, thus my own personal satisfaction. I'll give you an example. My experience in ICU is pleasant and gratifying. The whole overall experience I will never forget. Wherever my career will go, I will never forget my experiences with patients, with doctors, and family members. Overall, it has made me grow. It made me grow as a person. It has made me realize the value of caring. For patients, I forgot to tell you what are the type of patients that I had for this study. I had a 24-year-old with multiple stab wounds with 4 chest tubes. I had one who asthma, but the asthma was triggered by his using drugs. He lives in the street. And the other one also is on drugs, who was found in the bench in a park. And I think I had one hemorrhagic stroke and one more. So the patient said being in the ICU was a wake-up call. Those were the longest days of my life. I am thankful to be alive. So like this one, when he was talking to me, he was crying actually. Being in the ICU with a tube, meaning endotracheal tube, but I was awake. I feel like I messed up because of what I did. I used drugs that I got messed up. They told me that I almost died. I know that it was not from my emphysema or asthma, but because of the drugs. I was partying and partying, having fun. After being in ICU again, after many times of being there, thank God I feel much better now. I realize now that to take life for granted, and I was thinking, meaning that I should behave. So he was telling himself, behave, Richard, behave. By the way, that's not the real name. A wake-up call. When I was in ICU, I saw my family visit. I feel different. Family is very important to me. One importance of my family for me is unity. Everybody was there. To me, it impacts because I was running around in the streets. He actually sells drugs. And I'm doing negative things. So all this is just a wake-up call because I'm here, and my parents, the nurses, the doctors, seeing young people work here and having jobs, and they can still go on with their day without having to worry about the police, or if I sell this, I'm going to get fast money. This life is simple, just sitting up here and watching life is also short. I saw my family come, all my family came, and they talked to me about the situation, and it was a wake-up call. Okay, I missed the same, and wow, seems like there's a theme for drugs, right? I'm sick, and I've been sick. I'm thankful because I have been up and down the ladder. I'm still alive. I thank God I'm still alive. Life is beautiful. It was scary, but I left death behind. It is scary when you go through the experiences like that. It puts meaning to your life. I see me. I can just go out and do it again, and it's true, but I hope not, although I never say yes or no. Okay, family members. Again, the context is critical care. We have 2 patients to one nurse. So when family members go home, they said that the experience made me emotionally empowered. The experience strengthened my faith. So like this family member said, seeing my husband in the ICU with a tube, it was hurting me so much. I can't do anything about it. I'm trying to do whatever is necessary so he can feel better. So then I said, well, God, this is when you come in. I'm telling you, please, can you have mercy on him? And I started praying and fasting and doing all the things that my God looks for us to be humble and praise him and pray. I started doing them, and I saw the difference. Now, advocacy, you already know this. This is one of our biggest roles. You advocate for your patient. I do this every day in ICU when I was a nurse, especially the sedated and those on chemically induced coma. They cannot talk, they cannot tell you what they want, so every time anyone comes to the room with my patient, I always look, what do they want? Because the patient cannot say anything, so you have to know, you have to advocate for everything. So not just the patient's well-being, but for privacy and confidentiality. You do not talk about your patients outside. Advocate for their ethical issues like DNR, healthcare proxy, living wills, and advance directives, and offer information to the family about the present condition, procedures, treatment, equipments, and invasive lines. You have to explain what they have in their patient connected, and even just the phone numbers. Okay, for the nurse, I think being a nurse itself, said this nurse, Just the definition of a nurse is to advocate for the patient. One way of doing that is advocating for patient's confidentiality. I think I always mention to my class, for something like AIDS or HIV, it is an important issue, advocate for them, and also for issues like organ donation, advance directive, living wills, and DNRs. Okay, uncertainty. This is already in the literature that when a patient is critically ill, you don't know what's going to happen to you. So they said, you don't know what's going to happen. Am I progressing or not? Will I make it or not? They always ask the nurse. It might be hard to answer. Nurse, will I die? You might not be comfortable to answer that, so you can refer it to the doctor. Okay. Am I progressing or not? So this is an example. I had this funny feeling of both scared and worried. I was awake and I understood everything, but my speech was not so good. I always thought, what if I won't make it? Will my condition get better or no? And am I progressing or not? So basically just the same on that. I can skip on that. Okay. So the family member said, peace of mind when at home. What do they mean? This means that when they go home, they feel confident that the team, the ICU team, is taking care of the family member, that they're confident that he will be okay. That's what this family member is saying. It might be a different context if this is medical surgical, because they have like 6 patients minimum or something. Okay. So this is like the 3 sentences summary of my study, which took long to actually put together. The ICU experience among all the participants is interdependence, meaning the 3, nurses, patients, and family members. The patients, their family members, and nurses are one or intertwined. Adaptation in the ICU as experienced by the participants from these categories integrates family as a unit, physical care or comfort, physiological care, and psychosocial support, resulting in transformation. So now that I finished discussing the study, as in research, we always say, first of all, you think, what will I study? Where will I do the study? Who will I study? And when you have your research question, the methodology is applied. So for me, it's qualitative. But the most important question is, so what? So what if I did that? Then what comes after? Now I know the findings. So I taught research for 11 years. The so what question is very tough. So for my studies, the aim is, of course, as in any research, is to contribute knowledge to the literature, that you hope that the findings from your study will be utilized in practice so that you'll be able to change practice. How do you change practice? So if your findings are used by any institution, that practice will be changed in forms of protocols, practice guidelines, and something like that. So what I did with this is, after I did a study, my job as the researcher is to first present the findings of the study to the institution and the school. After I did that, I actually formulated some recommendations to the institution. So these are my recommendations. Safety and what is this? Of course, I have some policy proposal. That's why I said policy as one outcome of my study. Like, for example, simple stuff as cultural competence, routine pain management. But I also I said that allow the family in any time that they want to be in ICU. If you've been with a family in ICU, are you allowed any time? I wonder with the audience. Because my experience is only 2 hours in the evening and 1 hour at noontime. Then the ICU is locked.
I've seen 10 minutes on the hour.
Exactly. So what is the reason why they don't allow the family any time? Because they're thinking that the family members will be a hindrance when there are invasive procedures, and when there are invasive procedures and also like resuscitation, they don't also want you to hear what they talk about, the team, for legal purposes. But actually, the whole literature says involve the family. It's better outcome. But why did I do this study with these recommendations? Because it's not being followed. There's only maybe, when I did this, very few. Even my own hospital, I cannot mention the hospital, by the way, they told me, you know what they did? They told me the first time, didn't you work here as a nurse? Is that really what you want? I said, it's still my job as a researcher. I'll give you my recommendations. So also, I said here, develop systems for communication by telephone or email. If it is now, I will say including text. But that time, telephone or email. And also, allow the patient if they want to put, by the way, in ICU, you're not allowed to bring flowers. No balloons, no flowers, no nothing. But I said, please allow the pictures and the cards, nothing wrong with that, because they think the flowers can bring infection from outside. Okay, so mainly these are the 4 big recommendations. Family presence during emergency and invasive procedures, flexible and open visitation, conduct an interdisciplinary conference with family members, and include family members in interdisciplinary rounds on discharge planning. I can tell you right now, the most written in the literature is the first one. Flexible and open visitation, as I said, that's my experience, 2 hours in the evening, 1 hour in the noontime, or as what Luan said, 10 minutes in the hour. And I also can't forget my other previous experience when I feel like I'm a warden with the keys. After the visiting hours, the charge nurse goes and locks each door. It's all glass, so the family are looking like that. So it's really awkward. So the interdisciplinary conference with family members, I usually see it in my practice when they label the family as problematic, that okay, they'll do a conference. Or like if they keep complaining, okay, let's do a conference. Or also when, but it should be automatic for anyone who's been in ICU for 24 hours. But it seems like it's not automatic, like it's not done automatically. Include family members in the rounds, I can tell you as in never. This is the first one I wrote about for my systematic review, evidence-based systematic review, as in never. Once the rounds is gonna start, the first thing they do is scream at everyone out. That's in the ED, the ICU, and everywhere. I never seen family members included in rounds, so I was wondering, I said, let me write about that. And to tell you honestly, that's my second most cited article, and nothing much also done in the studies. So I drafted the policy. I have to remove the name of the institution just to protect. But I wrote this myself. I did first the definitions of what I'm proposing. So I want to ask you guys, if your mom is being resuscitated, flatline, would you want to be there? Okay, she said no. Acceptable answer. You would? Okay. We have different requests from family. Can you just let me hold her hand as you jump on her chest? I just want to be there when she goes. That doesn't happen. No way in the world. When we are coding the patient, only us, because they're scared that what we talk about will be interpreted differently and will be sued. So usually it's the team. There's like 10 people. But is it really wrong to include them? So this one is much written in the literature. I actually proposed the policy. It's quite long. I'm not going to read it. But there will be provisions if you are allowing them. First, you ask the family, for example, would you want to be there? If they say yes, okay, only one person. But the reason the institution don't like it, because they don't have a budget for the liaison person. Because there has to be somebody to make her sit somewhere in a lounge, give her some tissues, give her some water. There's a telephone that she could use. But they said no time for that, no resources for that. My job as a researcher, I gave it to them. I still follow up every now and then. There's a big resistance to it. What is the reason why we don't also allow? Some of them would faint. And what do we do if they faint? We take them to the ER. So that's another big thing. They don't want to be bothered usually. But I fight for it. I still advocate. So that's the whole policy. Okay, flexible or open visitation. I actually asked a week ago where I used to work. They said, sometimes they're flexible, still not. Like not anyone can just come in the ICU anytime. The moment you come in, they say, where are you going? Can we help you with something? You won't even get to you only get to the main door, but you won't be able to go inside. Maybe there's a little difference here in Pocono and Lehigh Valley. Okay, conference. I see in our ICU, as I said, they label those problematic. Okay, we do a conference, but it should be for patients who are mechanically ventilated or on life support, they should. 3 days is long already, actually. They should know, okay? And those patients with poor prognosis. Discharge planning, family should be there because they all don't go home. Some of them go to some, okay, so the so what question. So what's the one aim of the study is to contribute knowledge to the literature And then I hope that the findings of my research will be used to change practice. And that's what I hope. And it's my job as a researcher to follow up on the recommendations that I give. Even though there's resistance, I keep going. So I'm so happy that I have contributed some knowledge. Like, for example, for critical care, this is the first one I did. And actually, I see how many people read it or actually cite it, so I'm happy about that. But beyond that also, first was the critical care people who would read it, like the doctors, the nurses, who are able to read the journals that they know the findings. I noticed that some of the studies that I know that has been conducted is they don't publish the research findings. But you did so much work. I think this is where you could reward yourself. Publish what you did, because why keep the findings to yourself? Although depending on the topic, but I know some that are not published. I think nursing has to contribute knowledge to the literature. We are actually accused, sorry for the word, that our findings stays in the shelves and collect dust. Because thank God if it's published, but also very few would read it because maybe they're not allowed when they're working or they don't know the findings. So that's for policy, I gave you the policy, what I did. For evidence-based practice, by the way, I'm not going to read the definition, you already know, especially from nursing. Actually, the definition of evidence-based practice cannot be as such without including patients' preferences and values. This is pretty much subjective. This is the work that I deal with. It's pretty much qualitative. So I did some theoretical papers, which I used 3 theories. One is transformative learning theory by Mesereau, uncertainty and illness theory by Michel, and synergy model of American Association of Critical Care Nurses, some concept analysis, and then from a Roy model, which is conceptual paper. So I want to tell you about evidence-based practice, especially for nursing students here. Qualitative questions are never asked in evidence-based practice reviews. They are called meaning questions. Usually, evidence-based practice reviews, they deal with etiology, diagnosis, therapy, prevention, prognosis, but not qualitative questions. So that's what I work with, and it's actually very interesting, and it's actually quite very important. Qualitative studies are also ranked lower in hierarchy of evidence all the time. If this is like the gold standard is a random control trial, qualitative is the 6th, like below. But believe it or not, it's actually very much important because from qualitative studies are the findings, that's where you can get a hypothesis that you can follow up with quantitative studies. So nurse researchers should further establish frameworks or systems for the critical appraisal of qualitative research and use its findings in evidence-based literature reviews. Evidence from qualitative studies can play an important role in adding value to systematic reviews for policy, practice, and consumer decision-making. Evidence must extend beyond the current emphasis on empirical research and RCTs, that's random control trials, to the kinds of evidence also generated from qualitative studies. The rich understanding of the individual patient that emerges from qualitative research connects this evidence strongly to the elements of patients' preferences and values. Okay, so these are the systematic reviews from the study and some methodological papers. And the last one I did was a meta-synthesis, which is also inspired by the studies. So aside from that one, sorry about that. Aside from that one, I also like to mentor young upcoming researchers like you guys. And as I taught research for long, I like to help the young people who are interested with research, and I have done that before. Actually, I did mentor for 2 years high school students from the Bronx, 2 seniors from Bronx Center for Science and Math, and two juniors from High School for American Studies. And we actually were able to submit proposal, and I helped them with that 2 years. They come to me every Tuesday, and we did data analysis. I'll show you some pictures of that. This was in the Philippines. These two, they are in Cornell, actually. Marley and Sarah, oh, not Cornell, the other ones, the other set, they're in Fordham. And we were able to submit a proposal to accepted at it's actually a STEM program. And we were accepted to be in this. There's like 550 participants from all of New York. They were juniors, but I was so amazed. They were able to do data analysis with my guidance. And these two, they're the ones who are in Cornell. These are actually juniors. And they won second place. And the accolade is not for me, guys, it's for them. Actually, the certificate is for them, and they got $1,000. So, okay, that's our president and our associate dean. So that's it, actually. Questions? I hope I wasn't so long. Yes, Luan.
I have a specific one.
Sure.
Which screening test did you use when they got out of ICU to determine if they were?
Oh, it's an old one. It's from 1990. It's called Murphy and Clark.
Okay.
Yeah, an old one. But I like it. It's very simple. It just asks what's your name? What's the date today? Where are you? Who is the president? Yes, basically, yeah, it has that question. Now, if your patient will say it's Abraham Lincoln, then that's a different story, right? Then you score it, and then I think it's between 7.5 and 10, they are included. But then I also know because they are our patients, so I see them in the ICU. But that's the most common question they ask me actually. How did you know that? How did you interview them if they were on life support? I said, oh, after 4 days actually. And then I interviewed them twice, 2 times. So with the family members, I interview them wherever they want. It's like a coffee shop in New York. I did one in Panera Bread. I did in Little Italy. The nurses, though, in the unit on their break. By the way, I did not interview my own patients to avoid bias, okay? The manager gave me who I can interview. They gave me a list, and then I look at the criteria, and then I look for the criteria, and then if they pass the criteria, then I do it. Thank you for the question. Guys, question? Justin is smiling. You look at me, so okay.
Not right.
Casey.
Would you consider redoing the study in a different setting, like in the Poconos?
Good question. Actually, I followed up a study in the ED, same hospital. Not because I want to compare, what would I find? But there's some similarities. For family as a unit, I got it again, but it's termed differently. I did it, yes, and then I did combine both. But nice suggestion. I'm feeling my way, and yes, why not? Why not? Yes. Thank you for
The idea.
I have a very simple question.
Sure.
I'm just wondering, for critical care nurse,
Yeah.
how many patients typically, if you were a full-time critical care nurse, would be under your charge?
For one nurse, bedside
one
nurse,
nurse.
2.
Just 2?
Two.
So essentially never more than 2?
Not really, because it's a big job. It's very complex. That's why I like critical care, because my adrenaline is always up. I've had the most, like a lot of complex care that you give, but it's also gratifying because like when they're flatline and you bring them back and they're alive, I'm not saying that they'll be the same normal as you when we bring them back, like you put pacemaker and then you started their heart rate. It's good, but unfortunately, I see a lot of death also. It always comes in 3s. Sometimes in a day, I wrap 3 bodies, very hard. In a week, there's 3. In a day, there's 3. And actually, we don't have time to discuss, but one of my findings from the nurses is they're not able to get over. You have a death today, you have a death tomorrow, you have a death the next day. You're off for 2 days, you come back the same. So one of my suggestions actually is debriefing. It's actually called PTSD.
What about counseling?
Counseling as like one-on-one. Unfortunately, that's not offered by hospital because to them it's part of your job. So I will work on that maybe to write something about it, because that's one of my recommendations, but it's not out there. Oh, there's one program for nurses. It's called mindfulness. That's one, but nothing specific like this, because there is PTSD in psych, there is PTSD in critical care, very big actually in the literature, but I can talk for myself. I take care of these patients every day, and it's like nothing. You just wrap a body, you still go on break, you still eat, you don't cry, you go back. It's 12 hours, so very, very tough job. You have to have the stomach for it. When I was in ICU, like the number of years experience for the nurses, it's between 10 to 30 years. It took me 7 years to be on day shift because I was like the youngest. But they're very highly trained. No emotions, guys, when you work. I'm not saying that you're cold, but that's why I include family, because it's very tough for family. So you're feeling this, you're not getting over with your experience every day, but you also have to deal with the family. So it's very hard, very, very hard. Thank you. Am I over the time?
No, you're good.
Okay. What else? If I
I'll add
forget.
to your comment
Yeah.
about, please make sure you don't say things in
Yeah.
front of patients. I deal a lot with patients who have aphasia.
Oh,
And
yes.
so a big complaint of my clients is that even though they might have understood everything but not be able to communicate, and people will treat them like they understand nothing.
Yep.
And, so I had patients who remember distinctly hearing in
Very
ICU, they're never gonna survive, and if they do, they're gonna be a vegetable,
Oh, wow. Okay.
coming from doctors and
Yeah.
things like that. And I'll tell you, to this day, and it might be 4 years later, 5 years later, they're still angry when
Yes.
they talk about that.
Actually, we don't have time, but I have it in my narratives. As simple as patient said, I am here as a critically ill patient. I don't want my nurse to come to me and say, oh, I didn't do my manicure today. They remember. And the other nurse said, I did not pee yet. It's already 10 hours. And the other one said, I'm so hungry. Now they're worried. Is she okay? She did not eat yet for the last 8 hours. Does she knows what she's gonna do to me? Because this is already like in the evening, and the nurse is saying, I have a headache. It's all in my narratives. Actually, I have a headache. I haven't eaten yet.
They don't wanna hear about
They don't
the
wanna hear
nurses'
about
personal
that.
lives.
Oh, gossips. When
Oh.
we're coding, I can tell you from experience, but I'm not talking about my colleagues. Sometimes it can be helped that as you pump, you're saying, did you hear? The nurse supervisor is here to have her boobs fixed. And I'm not kidding, guys. It's true. Like, no gossips. They feel like, oh my God, she's taking care of me and she's gossiping like that. They hear everything. Actually, when they wake up from coma, I had my patient ask me, Brigitte, I hear something they're talking about Dr. So-and-so. I said, oh my God, I'm so sorry. I said, I hear it all the time, like what they talk about. So I always tell my clinical groups, do not gossip, even though they're not alert. I mean, they're not. The last thing that goes is the hearing. And when you take care of those patients who are not able to talk, I always say, I'm here today, I'm Brigitte, I'm your nurse up to 7 p.m., it's 7 a.m. right now. Right now, I'm gonna assess you first, head to toe. After that, I'm gonna suction you, and then after that, I'm gonna turn you to your side. Believe it or not, they know. Then I would say, blink your eye if you got me. And they blink their eye. So do not gossip, do not talk about personal issues or something like that. They totally know. And I totally understand what you said. My mom was a stroke patient for a year and a half. She was aphasic. She is very mad because she cannot say what she wants, but she understands everything. Oh my God, like she's pointing to me that they're saying this, but I know what it means. Do they know that I can understand, but I cannot express? There's different kinds of aphasia, guys, for our nursing students. So they can comprehend totally, but they cannot express, or they can express, but it doesn't make sense. So depending, okay? And there's a global one.
Combination of them, any
And there's a global
combination
one,
of
yeah. Anything else? I'll answer anything.
Brigitte,
Hi.
I'd just like to add to your comment about the nurses experiencing death in the hospital.
Yep.
From some qualitative research that I did with a colleague who's at
Mhm.
Moravian. The study was to look at nursing students and their reaction to caring for the dying.
Yeah.
And it definitely came out throughout all the themes that if they're going to experience death, the hospice designated facility was the best place to experience it. Because like they were saying, nurses and we brought that out as future research, where nurses in the hospital really need to be researched to say, what kind of support do you get?
Exactly.
How are you able to debrief? Is there a chaplain? Is there personal days for you dealing with so much death?
Yep.
Which we are finding not happening. So they're really very cut and dry about it. Okay, this one died, let's move them on. Versus nurses in the hospice setting.
Yep.
They said they felt so much better as a student because the nurse was talking about how they cry, how they
That's right.
interact with the family, how
Yep.
they're good friends with the family. So a lot of the things that you were talking about, but getting a positive feeling from having that experience, which is difficult enough, with individuals who are then allowed to tell their stories. Storytelling was very important.
Yes.
And being able to feel like, okay, I can be a normal person dealing with someone passing. And there are comparisons to seeing death in the hospital and seeing the reactions of the nurse was totally different.
Yeah.
And so then, we brought up about how nurses in the hospital
Yeah.
need to have support, and they don't. It's almost taken for granted, like you
Yes.
said, it's their job, but
Yeah.
they still have reactions to death and
Yeah.
patients dying and
Yeah,
family members.
I totally agree with Lori. Actually, yes, because the hospice is set for it. And the nurses, they're able to do that. But in my hospital, would you believe, they even took the chapel out. Because they said it denotes that the chapel is for Catholics.
Oh my gosh.
So there is no place for worship. I don't even want to use the word worship. There is no place for meditation, you would say, or like silence. Because they said it's a Jewish-run hospital, but the chaplain denotes that it's a Catholic faith. They took it out. Unbelievable. Now you cannot say, by the way, when we interview patients, I don't mean when we do admission assessment, they don't even want you to use what is your religion. That's what it says on the admission assessment, but they changed it to, do you practice any faith? Because some patients and family are actually offended. What do you mean religion? I don't practice any religion. So I always also tell my students, be very careful when you're doing admission assessment, say the right words. So isn't that something that they remove the chapel because it might denote something?
No acknowledgement of spirituality.
No. It's like business, just go, that's it, nothing else. Like, can you imagine the family if we're coding on your mom? The longest code I've been is 4 hours.
Oh my gosh.
The patient looks like a monster already. Well, first of all, you have to know, are we supposed to do this? Is the patient DNR, do not resuscitate, or do we just keep going? But the doctor has to have to say something. Sometimes I know for a fact, but I don't have the power to say we should stop. But you can say, I know already the patient is dead. It's flatline. Say, okay, let's put pacemaker. And we do it right there at the bedside. Yes, it will have something because it's a machine. But once it's still a patient is still dead. So sometimes, not as a regular bedside nurse, you have to be the charge nurse to say, Dr. Grantham, you always say the time, I think we're 3 hours already. We started at 7, it's already 10. Do you want to call it? Okay, don't get me wrong, guys, but I don't like if there's a code and they practice procedures on the body. I've been 20-year nurse, so I know exactly, okay. When they say, why don't you try pericardiocentesis? We'll see if the heart has some blood. The needle is this long, and the syringe is this big, and they poke the heart straight and do like this. Okay, if you cannot deal with that, you just go out and say, can somebody just cover me for the next few minutes, because you already know that is wrong, okay? There's a lot in critical care. You have to have the gut, and as a charge nurse, you have to have the command. Let's say, Doc, I think we have to call it because this is already long. And this happened to my actual coworker, but not in my hospital. They did 2 hours of code. She's my coworker, and I eat with her every 11 o'clock. They didn't want to quit. 2 hours already. She was so swollen already, and she's drowning because she has pulmonary edema and a global heart attack. Global heart attack meaning her whole heart. And can you believe that she was alert when they were bringing her to the hospital? And she said, bring me to my hospital. But that's not the law. The law is you have to be brought to the nearest. They coded her for 2 hours, and they told me that, oh, she looks like a monster already. And then finally they stopped. And I went to her funeral. She was like so mad. I'm literally telling you. I touched her face. By the way, we don't have open coffin in the Philippines when we have deaths. Never. We have a coffin, but we have glass on the coffin. But she's my colleague. I eat with her every day. And I touched her face. I said, I'm so sorry. She looks very mad, like I should not have died or something. But she was a 45-year-old with a heart, with the arteries of a 65-year-old. So they said that she had a global myocardial infarction or global heart attack because she never had an echo or an EKG at age 45. She had massive chest pain, and she was already drowning in pulmonary edema when she died. So I am glad that I am teaching nursing, so I share my knowledge with and actual experiences with my students, and it's my area, but there's so much research to be done. Thank you so much for your questions.